Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. We know your time is tight, so we're focusing today on a rapid but comprehensive analysis of a diagnosis that challenges every abdominal surgeon and physician out there: the interloop abscess.
That's a tough one.
It really is. We're drawing directly from the dense clinical and surgical guide you shared with us, and our mission is simple: to cut through the noise and distill the exact definition, the crucial diagnostic gold standards, and, of course, the detailed management techniques.
Especially that laparoscopic approach. That's where we really get into the weeds.
Exactly. The high acumen stuff you need in real time.
Well, this is a deep dive into surgical judgment as much as it is into anatomy. To start, an interloop abscess is precisely what the name suggests.
Right.
It's a localized, encapsulated collection of pus. But the key is where. It's situated specifically between loops of small intestine.
That's walled off.
Completely walled off. By adjacent viscera, the omentum, and this sort of fierce fibrinous adhesive process.
That location tucked away between the loops, that's the entire source of the problem, isn't it?
It is.
I mean, they don't typically announce themselves with the dramatic rebound and rigidity you see in generalized peritonitis. They're much more insidious.
Insidious is the perfect word. And yet the associated risks, we're talking prolonged sepsis, potential for bowel obstruction, and the dreaded intercutaneous fistula, the morbidity is just exceptionally high.
It's a silent threat.
It absolutely is. And as we delve into these technical details and management strategies, we have to be really explicit for everyone listening.
Okay.
This content is for reference and, synthesis only, based strictly on the sources you provided. All clinical practice, patient care, and final procedural decisions must strictly follow your local institutional and national guidelines.
That's a crucial point. We're here to synthesize the knowledge, not replace the judgment call.
Exactly.
Okay, let's get into the source material. If this is such a specific anatomical problem, where does the initial contamination usually come from? Let's unpack the etiologies.
We can categorize the origins pretty cleanly. The most common category is secondary peritonitis.
So a leak somewhere else.
A leak somewhere else. It results from a breach in the integrity of the gastrointestinal tract. So that could be a perforated appendicitis, a free perforation from diverticulitis, or even a peptic ulcer that sort of contained itself just enough to seed the area.
So an initial massive contamination event that the body heroically but imperfectly tries to wall off.
Precisely. The second major area of concern, especially for surgeons, is postoperative complications.
Well, this is a big one.
It is. And here, the number one culprit is the anastomotic leak. You see this after any small bowel or colorectal surgery, but it could also be, iatrogenic injuries or even an infected postoperative hematoma that becomes a bacterial focus.
And then there are the more chronic or inflammatory drivers to consider as well.
That's right. The inflammatory and ischemic group is crucial, and it's dominated by Crohn's disease.
Right.
When Crohn's develops that transmural inflammation or fistulizing disease, these interloop abscesses are a frequent manifestation. We also sometimes see a delayed presentation of ischemic bowel where a segment just necroses and leaks subtly.
And less common causes.
Yeah. Less commonly, you might be dealing with severe trauma or even some historical pathologies like abdominal tuberculosis or actinomycosis, which generate these incredibly complex matted adhesions.
The pathophysiology here is just fascinating. You mentioned the body's defense mechanisms, the omentum, the adhesions. But if the body walls it off, why is that resulting cavity so challenging to manage? Why does it settle between those mobile loops?
It's a race against time, really. The omentum and the fibrin matrix, they rush in to localize the contaminant, trying to prevent generalized sepsis.
A good thing.
A very good thing. However, because the small bowel is inherently mobile, that walled-off cavity forms between structures that are constantly shifting. And that mobility, that is the critical insight.
It dictates everything that follows.
Everything. It causes symptoms of partial obstruction, and more importantly, it makes percutaneous drainage PCD extremely difficult.
Because you can't get a clear shot.
You can't. When you try to place a needle, you run a very high risk of traversing and injuring the intervening mobile small bowel itself. The defense mechanism becomes the management hurdle.
That context is vital. So, given that mobility and the resulting insidious nature, let's pivot to the clinical picture. What are the subtle warning signs clinicians should be watching for?
The key is just a heightened index of suspicion. You're looking for systemic signs of infection that just don't resolve. A persistent fever, chills, tachycardia, and then lab evidence like a spiking white count and elevated CRP.
And the abdominal exam?
Localized pain is present, but it's often vague, sort of periumbilical or nonspecific lower abdominal tenderness.
I imagine the bowel function signs are a major red flag here, too.
They absolutely are. Signs of partial bowel obstruction, nausea, vomiting, distension are all common. But critically, in that postoperative patient, you have to watch for a persistent or recurrent ileus that just isn't following the typical recovery curve.
That's the one.
That is a massive red flag. We have to emphasize, though, the presentation is often extremely subtle, especially in immunocompromised patients or those on steroids. If a patient is not improving as expected, you have to investigate aggressively.
Which brings us to defining the enemy. We need definitive imaging before we commit to the OR or the IR suite. What's the tool?
Well, when we pull the trigger on imaging, the CT scan with IV and oral contrast is the undisputed gold standard. This is where the surgeon gets their roadmap.
And what are you looking for on that scan?
The Q findings are a discrete, localized fluid collection with a dense, enhancing wall, which indicates that inflammation and hyperepium.
The body's response.
Exactly. And crucially, you look for adjacent bowel loops that are visibly matted together. You'll often see air fluid levels inside the collection itself and that classic surrounding fat stranding.
Okay, what if the patient is unstable, can't make it to the CT suite? Any alternatives?
Ultrasound is viable for a quick detection of a complex fluid collection, especially in an unstable patient, but it lacks the anatomical specificity you need for planning.
And MRI?
MRI is technically superior for soft tissue, but it's rarely practical in an emergent setting. So really, the CT remains the cornerstone for surgical planning and, true diagnosis.
Once that diagnosis is confirmed, what are the immediate life-saving management priorities before we even think about source control?
We have to initiate immediate medical stabilization. This starts with aggressive IV fluid resuscitation and meticulous electrolyte correction.
Right.
Parallel to that, we start broad-spectrum antibiotics immediately. The source material is really clear about covering the usual suspects.
So give us the regimen breakdown. What are we aiming to cover?
We need robust coverage for gram-negatives, anaerobes, and enterococci. So standard empiric regimens. They often include a combination like piperacillin tazobactam, or maybe a carbapenem like ertapenem.
Sometimes with metronidazole.
Sometimes with metronidazole, yeah, depending on your local resistance patterns.
Okay.
And remember, if the patient's been previously treated with antibiotics, is critically ill, or immunocompromised, you need to consider fungal pathogens. Maybe add antifungals early.
Okay, beyond medical support, the primary clinical conflict is source control. This is where the decision points between interventional radiology and surgery really matter. What determines if we try PCD first?
Percutaneous drainage, or PCD, is frequently considered the first-line attempt, only if the abscess is well-defined and there is a clear, accessible route that avoids traversing normal bowel.
It's minimally invasive. It can buy you time.
It can, but based on the pathophysiology we just talked about, that mobility PCD often runs into trouble here, right?
That's what I was thinking.
Absolutely. The caveat is enormous, especially for interloop abscesses. PCD is a drainage procedure, not a source control procedure. If the underlying cause, the leaking anastomosis, the perforated diverticulum, is still contaminating the space, PCD is going to fail.
And finding that safe window.
It's often impossible. Inaccessibility and ongoing contamination are the two biggest drivers that send a patient to the OR.
So surgical drainage becomes mandatory when PCD fails, or when the underlying source demands immediate attention. We're talking definitive control.
Yes. Surgery is indicated if PCD fails, if the abscess is inaccessible or has multiple loculations, or if there's clear ongoing contamination. And a final point before the OR, do not forget nutritional support.
Good point.
Early enteral feeding is always preferred if they can tolerate it. But if you're anticipating a prolonged ileus, you need to be proactive about TPN.
Let's focus now on the part of the guide that demands the highest surgical acumen, navigating that hostile abdomen laparoscopically. This is the deep dive into technique. What are the strict prerequisites before a surgeon attempts a minimally invasive approach?
The indications are strict. The patient must be hemodynamically stable. You must not suspect a dense, frozen abdomen from multiple previous surgeries. And, critically, you need to have the available surgical expertise to manage a potential conversion.
And contraindications.
The absolute contraindications are hemodynamic instability, severe portal hypertension, or complex fistulas that just necessitate a massive open repair. And, of course, the inability to tolerate pneumoperitoneum.
So walk us through the key technical steps, starting with safe access.
Positioning is supine, arms tucked. For initial abdominal access, especially if the patient has prior midline scars, We often recommend the Hassan or open technique,
Away from the mess.
away from the mess. You might favor Palmer's point, that key spot in the left upper quadrant, to establish pneumoperitoneum at, say, 12 to 14 millimeters of mercury safely. Then your accessory ports go in under direct vision.
Okay, you're inside. And you're faced with matted, inflamed bowel. How do you safely separate those adhesions to expose the abscess wall?
This is the most dangerous part of the case, adhesiolysis. The cardinal rule is sharp dissection using scissors.
No energy sources.
You have to avoid energy sources electrocautery, especially near the bowel wall. The risk of delayed thermal injury leading to perforation is just too high. You use gentle, atraumatic graspers only to create countertraction. This is not a time for speed. It's a time for meticulous, deliberate separation.
So once you've carefully dissected down, you're at the abscess cavity. How do you enter and drain it safely?
The technique is specific. Blunt probing with a suction irrigator tip.
Blunt, not sharp.
Right. We do this to breach the wall without sharp edges or thermal injury. The abscess wall is often friable and thin. Once you're in, the pus has to be immediately suctioned out and sent for comprehensive culture, aerobic, anaerobic, and fungal. Then, copious suction irrigation with warm saline and gentle breakdown of any internal loculations under direct vision. You have to fully debride the cavity.
Drainage is temporary relief. Source control is the cure. How do you ensure you've addressed the underlying pathology laparoscopically?
Source control is paramount. Drainage alone is a recipe for recurrence. Once the cavity is clean, you have to systematically inspect the area for the cause. Is it a perforated appendix, localized diverticulitis, or is it that anastomotic leak?
And the management depends on what you find.
It does. Appendectomy for appendicitis, resection for diverticulitis. If it's a leak, management can range from primary repair with aversion to simple diversion. Or if the inflammation is overwhelming, maybe just drainage alone with a plan for delayed definitive surgery. The key is to see the leak and control the contamination.
Once the source is addressed, drain placement is next. What are the best practices here to avoid complications?
We detail the placement of one or two closed-section drains, like Jackson-Pratt drains. They have to be positioned immediately adjacent to the drain cavity.
Not inside?
Not inside, adjacent to. They must exit through dedicated lateral port sites. And a crucial technical point is ensuring the drain tip lies smoothly so you minimize the chance of the stiff tip eroding into the adjacent inflamed bowel wall later on. That's a common cause of iatrogenic fistulas.
And finally, the finishing touches irrigation and final checks.
Copious irrigation with saline is mandatory, but we have to avoid vigorous irrigation. You don't want to spread a localized infection. Then, a meticulous final check. You search for any iatrogenic enterotomy from the adhesiolysis, which must be repaired immediately, and you assure complete hemostasis before you close.
So we've successfully managed the procedure, but this is high-risk surgery. What are the key pitfalls and complications?
Well, the primary technical risk remains bowel injury during that challenging adhesiolysis. If you see it, you repair it immediately. But even with a successful procedure, patients face a significant risk of intercutaneous fistula later on.
From a missed injury or the drain itself.
Exactly. And this procedure also carries a substantial potential for conversion to open. The sources suggest between 20 to 30%. That high rate usually happens when the adhesiolysis is just too difficult or there's uncontrolled spillage. It's a true measure of the hostility of that abdomen.
And what stands out in special patient groups, like those with underlying inflammatory conditions?
In patients with Crohn's disease, the source material gives a clear mandate. Avoid resection if drainage alone is feasible.
Why is that?
Because resecting in the presence of acute inflammation carries a highly elevated risk of subsequent fistula formation or anastomotic breakdown in this specific population.
Okay, and postoperative cases?
For postoperative cases, the recurring message is high index of suspicion. If fever or ileus persists past day 5 or 6, just bypass the doubt and order that early CT. And for immunocompromised patients, their blunted inflammatory response means atypical presentation. You have to broaden your differential to include fungi or even mycobacteria.
So, wrapping up the clinical picture, what does this all mean for the patient in terms of recovery and long-term risk?
The outcomes are serious. Mortality ranges from 5 to 15%, and that spikes significantly if diagnosis and source control are delayed. Typical hospital stays, even with success, are between 1 and 2 weeks.
And long-term?
Long-term, these patients carry a persistent risk of developing adhesive small bowel obstruction, just from the extensive inflammation and scarring.
Let's synthesize this for clinical application. Distilling all the source material down, what are the 3 most critical takeaways for a surgeon dealing with an interloop abscess right now?
First, CT is the absolute diagnostic mainstay. Do not operate based on clinical suspicion alone. Get the roadmap.
Okay. Second, understand the clinical conflict. Initial drainage via PCD is ideal if it's accessible, but surgery is frequently required for these complex, multiloculated, or contaminated interloop cases.
And
Third, and perhaps most crucial, source control is paramount. Drainage is insufficient if that perforated appendix or leaking anastomosis is still present and actively contaminating the cavity.
if we connect this to the bigger picture, achieving those optimal outcomes requires a truly multidisciplinary approach. IR, infectious disease, critical care, surgery.
Absolutely. They all need to be collaborating from the moment the patient hits the door. No surgeon should tackle this problem in isolation.
The management of interloop abscesses really requires balancing timely drainage with definitive source control. It's a challenge that tests diagnostic acumen and surgical judgment simultaneously.
It really does.
It forces the surgeon to choose between temporary relief and definitive cure in a field of high anatomical risk. It's a true test of surgical mettle.
Well said. And that brings us to the end of our deep dive. We sincerely hope this distillation of the critical steps from pathophysiology all the way to laparoscopic technique proves valuable in your demanding clinical practice.
I hope so.
If you found this content helpful, don't forget to share this deep dive with at least one of your colleagues or friends and help us spread the word. Also, be sure to check out our YouTube channel and other social media pages for more detailed content. We appreciate you trusting us with your time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.